Hello, I am Dr. Forrest Cummings, internal medicine specialist, small animal, and today we'll be discussing hypoadrenocorticism or Addison's disease. Let me tell you a little bit about myself. As most of you, I've always loved to deal with animals, work with animals as a young child, and I knew from the beginning, at about the age of 9 or 10 years old, that I wanted to be a veterinarian. So I went to college. I went to the University of Kentucky for my undergraduate and majored in animal science with a biology minor. And from there, I went to Tuskegee University College of Veterinary Medicine and graduated in 2005 with my doctorate in internal medicine. After that, we ended up going to the University of Tennessee in Knoxville for my rotating internship. I initially applied for a medicine residency, but took a step back, decided that I wanted to do some emergency medicine and wanted to do some general practice. So I moved to Florida for a couple of years before starting my internal medicine residency. That was a 3-year program, completed that in 2011, and have been doing internal medicine ever since. I really enjoy endocrine diseases. Addison's disease is probably one of the most rewarding diseases to diagnose and to treat, and it's just a great disease, if that makes sense. It's a great disease because it comes with such an excellent prognosis. It can really, literally turn the life of that animal around, and you really feel like you've provided an excellent service to not only the animal, but also the families. Addison's disease is probably one of the most underdiagnosed diseases that we see in vet medicine. It's called the great imitator, and we probably, in my practice, see somewhere between 50 to 75 cases a year, mainly because it always mimics something else, which we'll discuss a little bit more in today's talk. But it's a great disease, and I really hope you enjoy the talk. So I just want to outline the talk for today. So I want to go over a little bit of adrenal anatomy, the physiology behind steroid synthesis, of course, the pathophysiology of Addison's disease, some of the diagnostics, some of the clinical signs that you can see, and then, of course, treatment options. And finally, I would like to conclude with a case presentation. So with steroid synthesis, we all know that the pituitary gland is going to release corticotropin-releasing hormone, and that's going to stimulate the anterior pituitary gland to produce ACTH. The ACTH is ultimately going to act on the adrenal glands to produce the 3 primary cortical hormones, the mineralocorticoids, the glucocorticoids, and the sex hormones. There are 3 major layers in the adrenal cortex: the zona glomerulosa, the zona fasciculata, and the zona reticularis. All 3 layers are going to produce important hormones, with the glomerulosa producing the mineralocorticoids that's going to control your salts, your potassium, your sodium, your chloride. And the fasciculata is going to produce your glucocorticoids or your cortisol, and the zona reticularis is going to produce your sex hormones, the estrogens or the estradiol and the testosterone. Through a series of pathways, cholesterol is broken down into any of the 3 adrenal cortical hormones. All cortical hormones are going to be derived from cholesterol. It is the lack of the 21-hydroxylase enzyme that will ultimately form your androgens. It is the presence of the 17-hydroxylase enzyme that's going to form your glucocorticoids. And then lastly, it's the lack of 17-hydroxylase that's going to form your mineralocorticoids. So what is Addison's disease? Addison's is just a deficiency of the steroids that your adrenal glands should be producing. It can be broken down into primary Addison's, which is the most common form that we tend to treat. That is a primary adrenal gland problem. It does not produce the hormones. You can have secondary Addison's disease, which is less common because secondary, it's usually affecting the brain. You can have a pituitary problem such as a tumor. You can have something going on in the hypothalamus causing a lack of production of your corticotropin releasing hormone. And you can also have iatrogenic Addisons, which is a form of secondary Addisons because you've given medications to suppress adrenal gland function, such as steroids, a very commonly used drug that we see in vet medicine and human medicine. So we tend to treat a primary Addison's, and that's the most common form. It's commonly seen in middle to young female dogs. Any breed can be affected, but we see it commonly in Great Danes, Rottweilers, Westies. You can see it in poodles, Portuguese water spaniels, bearded collies. It's extremely rare in cats, but on occasion we do see it. At my clinic, we probably see a case every couple of years in cats. So by and large, this is primarily a disease that's going to be affecting dogs. Some of the clinical signs that you can see can vary all over the board. Remember, I said this was a disease that's called the great imitator. You can see things that are as basic as lethargy, decreased appetite, vomiting, diarrhea, overall weakness. You can see increased drinking, increased urination. You could have abdominal pain. You could have shivering. The signs are very vague, very basic, which is usually why this disease goes undiagnosed in so many animals for such a long time. So because it is the great imitator, you have to have a list of possibilities when you see these animals present to your hospital. Things from primary intestinal disease, pancreatitis, small intestinal bacterial overgrowth, gastroenteritis, liver disease, kidney disease. You can have, presumptive pneumonia or tracheobronchitis. The host of possibilities is wide, and we have to have to include Addison's disease on that list anytime we see any of these problems going on or clinical signs going on, especially if that animal fits the signalment that we discussed previously. So how do you get to a diagnosis of Addison's disease? The most important thing is the history. You have to get a thorough history from the owner because that's going to help you to determine what test you need to run. And so generally speaking, you're going to start with your minimum database, which is going to include your CBC, your chemistry panel, your analysis, radiographs of the chest, of the abdomen. You may do an ECG, ultrasound of the abdomen. And then, of course, the gold standard is going to be to do an ACTH stimulation test. You want to be able to measure those steroid levels. It does not distinguish between a primary and a secondary cause, but this is always going to be the gold standard because ultimately you are trying to measure those cortisol levels. On your CBC, what you tend to see is the exact opposite of a stress leukogram because you don't have the steroids that will cause the stress leukogram. Remember, the stress leukogram is going to be your mature neutrophilia, an eosinopenia, a lymphopenia. With the lack of the stress leukogram, you're going to get a neutropenia. You're going to get an eosinophilia. You're going to get a lymphocytosis. You may or may not see red blood cell changes, such as a non-regenerative anemia. On your chemistry panel, you can see things like the classic Addisonian, which is going to be your hyperkalemia, the hyponatremia, and the hypochloremia. Some people use the sodium-potassium ratio as a gauge to say maybe this is an Addisonian. You hear numbers from less than 27-to-1 ratio to less than 23-to-1 ratio. This is not a pathognomonic abnormality, but it's something that you have to be aware of. Depending on the degree of hydration for your dog that you have, you may see them develop an azotemia. You may see them develop hyperphosphatemia, hypercalcemia, and you can also see hypoglycemia. Other things that you can see can be a metabolic acidosis because of the electrolyte imbalances that they're having. Your urinalysis changes are really going to be based on the hydration status of your dog. Depending again on the hydration, it may be a specific gravity that's elevated above 130, 140. You could have a specific gravity that drops somewhere between that 1008 to 1025. Addison's disease can range from as low as 1008 to greater than 1030. It really all depends on your hydration status, but more importantly, the takeaway is you cannot diagnose Addison's disease strictly based off of a urine concentration. You must take it in light of all of your other tests that you've been performing up to this point. And lastly, one other test that we may need to perform depending on the physical exam findings, but you may want to perform an ECG or an EKG. One of the classic symptoms that you can see with this is going to be elevated T waves and flattened P waves because of your electrolyte abnormalities. So why do you see these changes? Well, first you must understand and remember the physiology of steroid production, and ultimately what are these going to be these initiators and instigators to cause the body to want to make steroids in times that it needs to make steroids. Well, the biggest and most important thing is these glucocorticoids are stimulated by different stresses. Stresses can be things as simple as infections, urinary tract infections, skin infections. You can have tumors in the body. You can have any abnormal thing occurring in the body that causes the body to say, I need to get out of this stressful event. So the body then causes the hypothalamus to produce your corticotropin releasing hormone, and ultimately that's going to trickle down into your adrenal glands producing the steroids that you need. But remember, we have an Addisonian. They don't have the ability to produce that. So when your body makes these steroids, what are the effects of these glucocorticoids on carbohydrate metabolism? What are the effects on lipid metabolism and protein metabolism? Well, with carbohydrate metabolism, you have stimulation of gluconeogenesis, which is going to be producing amino acids from your extrahepatic tissues. It's going to cause decreased glucose utilization by your cells, and ultimately it's going to increase your blood glucose concentration so that you have that extra energy that you would need in times of stress. So if you don't have those glucocorticoids floating around, you're not going to see those changes. So you're going to have ultimately decreased blood glucose concentrations, which is one of the things that we saw on the previous chemistry panel. So glucocorticoids are also important in protein metabolism because it helps to store proteins in your liver for ultimately gluconeogenesis. It also helps to store extra fat when you need extra fat. If you don't have those things, your body can't make these energy stores that's crucial in times of stress. When you don't have these backup energy stores, you can't, when you need them, that's when you get yourself into a crisis. Addisonians, they cannot respond to that stress because they don't have the ability to do the things with protein metabolism, fat metabolism, and carbohydrate metabolism that non-Addisonian dogs and people can. I think one of the most common things that we see with the glucocorticoids are its anti-inflammatory effects. It can help to decrease capillary permeability. It can help suppress your immune system when you have to treat for autoimmune diseases. It helps lower fever. It helps to push out white blood cells or cause that neutrophilia to help in times of stress. It helps stabilize cells, cell membranes. The effects of glucocorticoids are very important in fighting normal inflammation within the body. And if you don't have that, then you can see the detrimental effects of it. So what initiates the mineralocorticoids? Two big factors: elevated potassium or hyperkalemia, and hypotension or low blood pressure. So ultimately, the purpose of your mineralocorticoids are to maintain your electrolytes and to maintain your blood pressure. However, when you're an Addisonian, you don't have that ability because you're mineralocorticoid and glucocorticoid deficient, which leads us into treatment options. The most common treatment option is going to be a combination of desoxycorticosterone pivalate, also known as Zycortal. It is an injectable subcutaneous shot that's given once every 25 days on the low end, up to about 6 weeks, but given subcutaneously as that injection to help replace those mineralocorticoids that they're deficient. The second drug in that combo is prednisone or prednisolone orally that you would give on a daily basis, generally at much lower doses than you would use to treat inflammation and autoimmune disease. So physiologic doses of your prednisone are going to be around that 0.1 to 0.25 milligrams per kilogram daily dose. Low enough to where you do not see the effects of excessive glucocorticoids or prednisone, such as increases in thirst, urination, panting, the things that you would think about when you give dogs high-dose steroids to help treat whatever ailment that they have. Another medication that can be used to treat mineralocorticoid deficiency is a medication called fludrocortisone. It is also called trade name Florinef. It's a great medication to control mineralocorticoids. The biggest disadvantage to it is that it has to be given daily as opposed to potentially every 4 to 6 weeks, like your DOCP or Zycortal. The other disadvantage to that is that it does have appreciable glucocorticoid effects. So when giving the Florinef, you can potentially see side effects of glucocorticoids, such as increases in thirst, urination, panting, and appetite, the things that you want to avoid. So the advantage of doing the combination therapy of the DOCP and the prednisone is that you can titrate your prednisone down to the lowest effective dose, avoid the clinical signs of excessive steroid use, and then you have a second medication that can control your mineralocorticoids exclusively. So in some cases of Addison's disease, you'll actually see these cases on an emergency basis because of severe dehydration and electrolyte imbalances. So sometimes they may have even collapsed at home because they're so weak. So when you get a dog that comes in collapsed, you run your labs, you may notice that you're extremely hyperkalemic, hyponatremic, extremely dehydrated, hypoglycemic. So when you do that and you need to talk about fluid resuscitation, things that you need to consider is which fluid type do I use? The obvious choice would be, well, I need a potassium-free fluid. So you would go with a 0.9% sodium chloride. You want to really push that in to get the hydration and fluid volume back up. You may need to administer 2.5%, 5% dextrose if they're hypoglycemic. It's never wrong, especially if you're thinking that this may be an Addisonian, to administer a shot of dexamethasone steroid IV just to get some steroids into their system in the event that they are shocky. You don't always have to, I shouldn't say always don't have to, you should never administer your mineralocorticoids on an emergency basis, because the effects of the mineralocorticoids are not going to be seen for approximately 10 to 14 days. Remember, what's causing the problem right now is the extreme hyperkalemia, which you're going to correct with your fluids and rehydration. It's the glucocorticoid deficiency, which you're going to correct with the dexamethasone. It's the hypoglycemia, which you're going to correct with your dextrose infusion. You get these things going, careful not to administer prednisone or prednisolone or predacetate because that can alter your ACTH stimulation test. Dexamethasone SP is the only glucocorticoid that you can administer just prior to an ACTH stimulation test without getting a picture back that looks like an iatrogenic Addisonian. So please keep that in mind. The most important thing during an emergency of an Addisonian crisis is fluid resuscitation and electrolyte imbalance correction and correction of the glucose. Once you get those things going, go ahead and do the ACTH stimulation test. You should be able to get those answers back within 24 hours from your reference lab so that you can start the appropriate long-term therapy. Oftentimes, these dogs that come in an Addisonian crisis are generally in the hospital for probably 2 to 5 days before they are back to feeling like themselves, eating, drinking, normal activity, electrolyte imbalances have been corrected, and now you can proceed with long-term management of the Addisonian. So now I just want to talk about Addison's disease in a more clinical manner. This case is one that I was involved in some time back, but I want to just bring it to light and point out some of the things here. Atticus, he was an 11-year-old male-neutered German Shepherd who had presented in January of that year with just very vague symptoms. He had some respiratory signs, presumptive tracheal bronchitis or kennel cough. He had some waxing and waning appetite. He had lost a couple of pounds. He had been in and out of his vet's office for just general supportive care, antibiotics for the kennel cough, presumptive kennel cough, and anti-nausea medications for the gastrointestinal signs. Ultimately, by the time I had seen him for the first time, which was in August of that year, he had lost 16 pounds. He never fully recovered. He had continued to have intermittent but persistent vomiting, diarrhea, coughing, respiratory signs. And so when he was referred to us, our problem list was the weight loss, the lethargy, the increased lung sounds and coughing, vomiting, anorexia. He was febrile on our presentation. He was very irritable and having mood swings, as the owner described it. On physical exam, he never showed any signs of aggression toward us. And he also had some mild submandibular lymph node enlargement. And so, one of the things that the owner attributed to a bunch of his symptoms with the lethargy and the mood swings was they had just acquired a new puppy. So they were wondering if he was just irritated with the puppy, trying to play with him. And then they also wondered, why is he not getting over his pneumonia and what's really happening? Why does he continue to vomit? Why is he continuing to lose weight? So he was referred to us during my internship, and we started the workup to help figure out what was going on with Atticus. So after we had our problem list formulated, we decided to proceed with diagnostic testing to help figure out what was going on with Atticus. We performed a CBC chemistry panel. He was too dehydrated at the time to collect urine for a urinalysis, and we also started with some thoracic radiographs and abdominal radiographs to assess the coughing as well as the gastrointestinal symptoms that he was experiencing. The CBC showed a hemo concentration. His red blood cell count was elevated hematocrit. He also had a mild neutropenia, and he had a lymphocytosis. On the chemistry panel, he was mildly hypoalbuminemic, hypocalcemic, hypoglycemic, hypocholesterolemia, and the electrolytes were actually normal despite the gastrointestinal changes. The radiographs were consistent with an aspiration pneumonia, mild, but consistent with an aspiration pneumonia. And so some of the supportive care things that we had started were IV fluid support, just supportive care for the nausea that he was experiencing, and broad spectrum antibiotics. We had seen him initially on the emergency service, so he was transferred to the internal medicine service the next day for a continued workup. So Atticus was transferred to the internal medicine service for continued care and additional diagnostic tests. They performed an ACTH stimulation test and an abdominal ultrasound. The ultrasound did not reveal anything obvious to cause the vomiting, to cause the just the general signs that we were seeing, the decreased appetite, no evidence of pancreatitis, gastroenteritis, the adrenal glands, they were visualized. However, you cannot make a definitive diagnosis of Addison's disease based on adrenal gland size. It's a function test. You need to measure your steroid levels. So when they did the ACTH stimulation test, it came back consistent with a glucocorticoid deficiency. The cortisol levels were undetectable. Remember, the electrolytes have been normal throughout this whole process. This is called atypical Addison's, where your electrolytes are actually normal. You don't see the hyperkalemia, you don't see the hyponatremia that's generally seen with an Addisonian dog. You just have the glucocorticoid deficiency. And so Atticus was administered dexamethasone intravenously, and followed by prednisone orally the next day, the next 24 hours. And he was continued to be treated supportively for his nausea with antiemetics, continued to be rehydrated. By the next day, he was actually starting to eat and feel a little bit better after receiving the steroids. So he had already started to turn around and show signs of improvement. He wasn't normal, but we had an answer, we had a diagnosis, and now it was just a matter of starting him and maintaining the steroids that he was lacking. So I hope you enjoyed the case presentation of Atticus. The reason I bring that case up is because I want to really, point out the fact that Addison's disease can present in so many different ways. I presented earlier atypical signalment, and Atticus fit none of it. He was an 11-year-old dog. He was male. He was a German Shepherd. He had been sick for essentially 8 months that we had known about, and never went into an Addisonian crisis. From the beginning, he did not fit the textbook presentation of Addison's disease. So I talk about the case to hopefully make people think a little bit more about the cases that they see, so they don't brush over the fact that they may have the Addisonian that doesn't fit the typical picture that we learn about, but it's always a possibility. So that's the basics of Addison's disease. If you have any questions for me, you can catch me on LinkedIn. Thank you so much for watching.